We're going to discuss obstructive sleep apnea in the context of surgery, anaesthesia, and in particular pre-assessment. First of all, which patients are likely to have it? Between 5 and 10% of the population are likely to have sleep apnea, and it's thought that it's twice as common in patients presenting for surgery. Obese people are more likely to have it. Men are affected twice as commonly as females. A neck circumference in excess of 40 centimetres is a risk factor, as is smoking and excessive alcohol intake. Pathology of the airway and craniofacial abnormalities are also significant risk factors. What's going on with patients with obstructive sleep apnea? Basically, there's an imbalance of two forces: collapsing forces associated with inspiration and dilator forces of the airway, which is to do with normal coordinated muscular function around the upper airway. This imbalance leads to obstruction, which may be partial, causing snoring and apnea and hypopneas or reduced breathing, and complete, causing apnea. Obstructive sleep apnea is primarily managed by physicians. The investigation of choice would be polysomnography or a sleep study. This investigation produces two primary indices. First of all is the apnea-hypopnea index. This gives a representation of the number of occasions of apnea, i.e. complete cessation of airflow, per hour, and hypopnea being more than 30% reduction in airflow occurring every hour. The oxygen desaturation index gives an indication of the number of times that the patient's oxygen saturation has dropped below 94% per hour. An AHI of 5 corresponds to mild, 10 moderate, and more than 30 would be severe obstructive sleep apnea. ODI of more than 5 occasions per hour would be considered significant. Consequences of obstructive sleep apnea for the patient are an increased incidence of cerebrovascular disease. Cognitive dysfunction and depression are more common and are largely thought to be due to the excessive tiredness that occurs in these patients. They're also more susceptible to certain metabolic syndromes and are likely to develop systemic and pulmonary hypertension, both of which can lead to significant heart failure. Here's an anaesthetist. These patients cause us worry when we see them. They're more likely to develop serious cardiovascular complications such as ischemia, arrhythmias, or consequences of heart failure perioperatively. Pulmonary complications are also more common, again serious things such as pneumonia, aspiration. They're more likely to have airway-related complications. The incidence of reintubation and admission to ICU can also be significantly higher in these patients. So, what do we do in the pre-assessment clinic? Well, time is often the greatest problem here, in that the delays which would occur by referring patients for polysomnography may often be excessive and may also not be necessary for some patients. So the emphasis is really on screening to see which patients are at risk. And the way we do this is using the stop-bang questionnaire. This is composed of questions relating to snoring. Does the patient snore loud enough to be heard through closed doors? Do they get frequently tired in the daytime such that they can drop off to sleep very easily? Has anybody ever observed them stopping breathing at night? Are they treated for high blood pressure? Is their BMI more than 35? Are they aged more than 50? Neck circumference more than 40 centimetres? And are they male? So a yes to any of those scores 1 point, maximum score 8. So once the stop-bang questionnaire is done, how do we then act on it? If the score is high, 5 to 8, they're at high risk of significant sleep apnea. These patients need to have their notes reviewed by the anaesthetist, who will make an assessment of their comorbidities, the type of surgery that they're having, and whether or not appropriate risk mitigation strategies can be put in place and they can proceed to surgery, or if surgery should be postponed and they should be investigated further. If the score is between 3 and 4, again, and the patient is being lined up for a day case procedure or could possibly be going to West Cornwall or St Michael's Hospital, again the notes should be reviewed by the anaesthetist to decide on whether or not they are appropriate for surgery in either of any of these settings. Those with a score of 3 to 4 who are scheduled for an inpatient procedure at Trelisk can proceed to surgery, where the anaesthetist will take the appropriate risk mitigation strategies perioperatively. Similarly, those with a low score of 1 to 2 can proceed to any type of surgery. What about the case of known sleep apnea? Those that have severe problems indicated by an apnea-hypopnea index in excess of 15 or baseline oxygen saturations less than 94% should have their notes reviewed by the anaesthetist. Those with mild known sleep apnea being lined up for a day case or peripheral site operation should also be reviewed by the anaesthetist, who will make a decision on their suitability for these places. Patients with mild sleep apnea scheduled for inpatient procedures at Trelisk can proceed to surgery. So to summarise, obstructive sleep apnea is an important condition that can have significant influences on the patient's cardiovascular and respiratory function. It can be a problematic condition, particularly if the patient is having major surgery and if the surgery requires a significant amount of post-operative opioids, and care should be taken if a day case procedure or procedure at peripheral site is being considered. Therefore, in cases of suspected sleep apnea, a stop band questionnaire is performed. A high score of 5 to 8 requires notes to be reviewed by the anaesthetist. If the score is 3 to 4 and a day case or peripheral site procedure is being considered, again the notes should be reviewed for suitability for these sites by the anaesthetist. Otherwise, the patient can proceed to surgery. If the patient has known obstructive sleep apnea, those with a high apnea-hypopnea index, remember that's the number of events, either apneas or hypopneas that occur per hour, should be reviewed by the anaesthetist. That would be a score of more than 15. Those with mild obstructive sleep apnea, a score of less than 10, can proceed to surgery and will require their CPAP to be brought in with them. Thanks very much for taking the time to listen to this. I hope it's been of some use. I'm very happy to receive any feedback that you may have on this and also any questions that it may have arisen. Thanks very much.